Good evening. This evening I'll be talking about acute kidney injury and sepsis, or what is commonly now termed as sepsis-associated acute kidney injury. So this is going to be the outline of my talk. We'll just look at the new definition of sepsis, and we'll go a bit about on the pathogenesis of sepsis as well. We'll talk about the prevalence of acute kidney injury in sepsis and the pathogenesis of acute kidney injury in sepsis. Talk a bit about the diagnosis of acute kidney injury and the management of sepsis-associated acute kidney injury. So if you look at sepsis, all of us, I'm sure, have dealt with sepsis at one point or another, be it in the clinic, be it in the wards, be it in the intensive care unit. And we know that it's one of the most common reasons as to why patients get admitted to the hospitals. And it is a syndrome of physiologic, pathologic, and biochemical abnormalities, which is induced by an infection. And it is a major public health concern, accounting for more than 20 billion US dollars of the total hospital costs. Unfortunately, the reported incidence of sepsis has been exponentially increasing. And currently we have the pandemic of COVID-19, and we know that almost everywhere in the world, the hospitals are being overwhelmed and the health systems are also being overwhelmed as well. Although the true incidence is unknown, the conservative estimates indicate that sepsis is the leading cause of mortality worldwide. We all know that whatever the patient is admitted with in the hospital, be it because of a malignancy, be it because of acute kidney injury, be it because of a myocardial infarction, most of the time it is sepsis that will lead to the cause of mortality, and this is worldwide. Patients who have survived sepsis and septic shock and who have ended up in the intensive care unit because of sepsis often have long-term physical, psychological, and cognitive disabilities. So if you look at the new definition of sepsis, or what is known as sepsis 3, it is defined as a life-threatening organ dysfunction, which is caused by a dysregulated host response to infection. So normally the host response to infection is an inflammatory response. And what happens is that this inflammatory response becomes unchecked and unregulated, and this leads to organ dysfunction. Now, organ dysfunction clinically can be identified as an acute change in the total SOFA score, which is a score of more than or equal to 2 consequent to an infection. So a SOFA score of more than or equal to 2 reflects an overall mortality of 10% in a general hospital population. And the SOFA score basically consists of the 3 variables, which is alteration in mentation, a systolic blood pressure of less than 100 millimeters of mercury, or a respiratory rate of more than 22 per minute. And septic shock is a subset of sepsis in which the underlying circulatory and cellular metabolic abnormalities are profound enough to substantially increase mortality. And this can be identified with the clinical construct of sepsis, with persisting hypotension requiring vasopressors to maintain the mean arterial pressures of more than 65 millimeters of mercury, and having a serum lactate of more than or equal to 2 millimoles per liter, despite having adequate volume resuscitation. So it basically defines hypoperfusion. And with these criteria, mortality is in excess of 40%. So if you look at the epidemiology of sepsis by itself, current estimates suggest that over 750,000 cases of sepsis are diagnosed annually, resulting in more than 200,000 deaths. Now, this is in prevalence in the US. The incidence rate for sepsis has been increasing over the past 2 decades, and it's the 10th leading cause of death in the United States and accounts for more than $17 billion in direct healthcare expenditures. Now, one important thing to remember is that we cannot establish a primary site of infection in up to 10% of patients with what we used to be called severe sepsis before. The most common site of infection would be the lungs, followed by the abdominopelvic region, and then the urinary tract. So if you look at the mortality, as you move from sepsis to septic shock, the mortality exponentially increases. In sepsis, you have a crude mortality of 15%. And by the time you're reaching septic shock, your mortality has gone to almost 50%. So it's very important to see that we need to act quickly by the time we get a patient with sepsis. The causative organism still remains gram-negative bacteria, although now we're even seeing increased prevalence and incidence of gram-positive bacteria like your Staph aureus. Fungal infections are also on the rise as well, especially with the use of invasives, with the use of broad-spectrum antibiotics. So we are seeing more and more of fungal infections, especially in the critical care units. A bit on the pathophysiology of sepsis. Once when you get either your gram-positive or gram-negative bacteria, their cell wall contains pathogen-associated molecular patterns. Now, for gram-negative bacteria, these are the lipopolysaccharides, and for the gram-positive bacilli, it's the peptidoglycans. So the binding of the lipopolysaccharide or the peptidoglycans to the toll-like receptors, either 4 or 2, subsequently leads to downstream signaling, and there is the translocation of the cytosolic nuclear factor kappa B into the nucleus, which then leads to transcription of the cytokines, including your tumor necrosis factor alpha, your interleukin 1, interleukin 6, and even interleukin 10. And these now subsequently lead to the activation of the immune system. Sepsis also leads to increased production of your inducible nitric oxide from the macrophages, and this leads to increased vasodilatation. There is damage to the endothelium as well from the cytokines, and this leads to increased permeability of the capillaries and the microvasculature. Subsequently, there is also the activation and binding of the macrophages and subsequent release of your prostaglandins, leukotrienes, proteases, and oxidants, which are quite detrimental to the organs and to the tissues. There's also a procoagulant response in sepsis because of the damage to the endothelium. There's a release of the tissue factor, which subsequently activates your coagulation cascade. And this subsequently leads to formation of fibrin, and then there is subsequent formation of clots within the microvasculature. And this becomes widespread. It affects all the organs, and it's not a must that it only has to be within the organ where the focus of infection is. And this is what now subsequently leads to multi-organ dysfunction. Because of the sepsis and the various cytokines produced, the factors that basically keep the coagulation cascade in check, your antithrombin 3, your protein C, protein S, are also downregulated, and the coagulation cascade goes unchecked. So there are increased inflammatory mediators like interleukin 1, TNF, interleukin 6, which basically lead to uncontrolled inflammation. And all this is based on animal studies. In a study in children with meningococcemia, your TNF levels directly correlated with mortality. However, the TNF antagonists, your anti-endotoxin antibodies, IL-1 receptor antagonists, and even your protein C agonists fail to show any benefits. So the other counter argument against this was that patients with rheumatoid arthritis who are treated with TNF antagonists also developed infectious complications and septic shock as well. So is it also a failure of the immune system to eliminate the microorganism? So studies have shown that later on in sepsis, there's a shift from the inflammatory T helper 1 cells with the anti-inflammatory response to T helper 2, which leads to energy and apoptosis of the B cells, the T cells, and the dendritic cells. There's also loss of the macrophage expression of the MHC class 1 and co-stimulatory molecules, and the immunosuppressive effect of the apoptotic T cells, apoptotic cells. So is it that the fact that now we have reduced the inflammatory response and this causes an overwhelming infection? So this was a post-mortem study looking at the spleens of the various patients who died from sepsis and trauma. And the patients who died from sepsis basically had very much reduced B cells in the lymphoid follicles. So there are various factors that influence the immune response to sepsis. One is, of course, the virulence of the organism. The more virulent the organism, the more the sepsis is going to be. The size of the inoculum is also important. Patient coexisting conditions like HIV, malignancy, post-kidney transplant, the nutritional status and the age of the patient are also very important. Genetic polymorphisms play a key role because you can have the same subsets of patients, and one patient will basically go on to develop septic shock and not respond to your antibiotics, while the other patient basically responds to antibiotics and just gets well soon within a few days. So what do septic patients die from? The septic patients actually die from multi-organ dysfunction, as I explained in the earlier slides, because of the excessive host inflammatory response and the cytokine storm that follows and leads to multi-organ dysfunction. Our goal is basically to prevent multi-organ dysfunction, and among the organs that we would like to preserve and make sure that there are no damage is our kidneys. So if you look at acute kidney injury and sepsis, acute kidney injury is frequently associated with sepsis, and almost half of patients who develop sepsis, especially in the intensive care unit, tend to develop acute kidney injury. And sepsis is the most common cause of acute kidney injury in critical care patients, like what the previous speaker, Dr. Sakpala, had alluded to as well. And they account for up to 50% of cases in the intensive care unit. The AKI incidence rate and severity correlate with the severity of the underlying sepsis. So as you move from sepsis to septic shock, you do tend to get a higher grade of your acute kidney injury, and the rate of recovery is also going to be prolonged as well. Sepsis-associated AKI, as is now commonly called, is a hallmark of severe sepsis and septic shock. And it is associated with worse outcomes, including a prolonged length of hospital stay, fewer ventilator-free days, and increased mortality compared to patients with non-septic AKI. As individual syndromes, sepsis and AKI render the host susceptible to each other. Although sepsis is the most common contributing factor for developing AKI, we should remember that acute kidney injury of any origin is associated with a higher risk of developing sepsis. So any patient who comes in because of acute kidney injury has a high risk of actually going into sepsis and subsequent septic shock. Sepsis has a unique and complex pathophysiology, as I explained earlier on. Identifying the exact onset of injury in sepsis is nearly impossible, leading to difficulty in timely intervention for the prevention of renal injury. So we don't know at what point in time does your injury to the kidney set in, because remember that among the things that we tend to use to identify kidney injury is your creatinine, serum creatinine. Unfortunately, serum creatinine is a, a late biomarker of acute kidney injury, because you know that up to 25% of the creatinine is actually secreted through the proximal convoluted tubule. So by the time that you are getting a rise in your creatinine, quite significant damage has set in to the kidneys. Remarkably little is known about the epidemiology of sepsis-associated acute kidney injury. And this is most likely because of a lack of coordinated epidemiology between sepsis and acute kidney injury criteria, and among researchers working in these areas. Remember that we got the definition of acute kidney injury quite late, and before it was a very heterogeneous definition, and this is why we did not have much data from before, even about the acute kidney injury. The term sepsis-associated AKI has just been coined recently, so this is why there's not much work that has been done for sepsis-associated AKI. Now, extrapolating from rates in United States, Adhikari et al. Estimated up to 19 million cases worldwide annually, but of course the true incidence is presumably higher. For patients in the intensive care unit, sepsis is found in 40 to 50% of patients with acute kidney injury. This was another study in an ancillary analysis of a multi-center randomized control trial in septic shock, including more than 1,200 patients. Acute kidney injury was present at enrollment in the emergency department in more than 50%, and another 18.7% developed acute kidney injury within 7 days. So by the time a patient is presenting with septic shock, their chances of developing acute kidney injury are significantly high. 1 in 2 patients will definitely develop acute kidney injury at the time of admission. And a further almost 1 in 5 more will actually develop acute kidney injury within 7 days. Important to note is that the relapse of acute kidney injury is also quite common after recovery. So we should not relax after we have gotten a recovery of our acute kidney injury, especially in our septic patients in the intensive care unit. Because a lot of times when we've been called to see patients, we realize that even after the creatinine improves and the urine output improves, there's always a high chance of the patient relapsing back into acute kidney injury and the serum creatinine going up and the patient becoming oliguric again. So we should never let our guard down. Almost 1/3 of the patients experience acute kidney injury relapse after the initial acute kidney injury reversal. Now, what happens to these patients who are discharged and who recover? So the long-term outcomes of patients with sepsis-associated AKI has been shown to be determined by, one, the severity of the AKI, and two, the recovery status at discharge. So if the grade of AKI was severe and the patient required renal replacement therapy, then chances are that the long-term recovery, the long-term recovery would be hampered. If the recovery status at discharge, if you discharge the patient at akin stage 2 or even stage 3, then the recovery will be more prolonged as well. And chances are that the patients might not go back to complete recovery of the acute kidney injury with a normal renal function. So what's the definition of sepsis-associated acute kidney injury? So it is usually defined as acute kidney injury in the presence of sepsis without other significant contributing factors, explaining the acute kidney injury or characterized by the simultaneous presence of both sepsis and kidney injury. Now, this is a bit difficult because remember that by the time we are being called, the patients have actually been on a number of drugs, including some of them are actually nephrotoxic drugs as well, like amikacin. So we don't know whether it's a sepsis per se that has caused the acute kidney injury, or is it the drug amikacin, or sometimes the patients have basically been on PPIs unnecessarily. And remember that PPIs are among the common causes of acute interstitial nephritis as well. Sometimes the patient comes in with both sepsis and kidney injury simultaneously. So why is sepsis AKI important? So this question was posed, that is the mortality of septic AKI higher than that of sepsis without AKI? And this was a study that basically looked at acute renal failure in patients with severe sepsis and septic shock, okay, with a significant independent risk factor for mortality. These were results from a German prevalence study. And they had almost 4,000 patients who were screened, and they got 415 with severe sepsis and septic shock. This was an old study, that's why we're using the terminologies of severe sepsis and acute renal failure. So 14 basically were disqualified because of the fact that they had pre-existing CKD, and they got 234 patients without acute renal failure and 166 patients with acute renal failure who had severe sepsis and septic shock. The in-hospital mortality, as you can see, was 67% in the patients with acute renal failure, while it was 42.8% in the patients without acute renal failure. And this was statistically significant. So what they concluded was that from this study, acute renal failure was the only organ dysfunction that was predictive for mortality. The odds ratio was 2.112 with a p-value that was quite statistically significant. Meaning that if you have a patient who has sepsis-associated AKI, the chances of the patient actually not making it or dying are almost 2/3, as opposed to a patient with only sepsis without AKI. So it becomes very important to know, to identify, one is to identify the patients with sepsis-associated AKI, and two is to treat appropriately these patients with sepsis-associated AKI. The second question that patient posed, that was posed, is that is the mortality of septic AKI higher than that of AKI secondary to other causes? So this is the cohort of patients with only AKI from any other cause versus AKI that was caused by sepsis. And these were two studies that were looked at. The first one was basically looking at patients with acute kidney injury, and there were two cohorts: the patients without sepsis and the patients with sepsis. And the patients without sepsis had a lower mortality as compared to the patients with sepsis-associated AKI. The other study basically looked, again, this was in the Journal of Critical Care, and they looked at patients with sepsis-associated AKI, and they found that the survivors, the mortality was significantly higher in the patients with septic AKI as compared to the patients with AKI that was not related to sepsis, and it was because of other causes. And all of these were statistically significant as well. So there are three models of AKI and sepsis in terms of the presentation. So one is that the patients come in with sepsis and then develop AKI, or the patients come in with sepsis and AKI at presentation, or the patient comes in with AKI and subsequently develops sepsis. Remember that AKI can predispose a patient to sepsis. Patients with AKI are at a higher risk of developing sepsis because of the uremic milieu that is within them, and this basically leads to a state of immunosuppression, and they can get sepsis-associated AKI. So the post-hoc analysis of the PICARD study of acute kidney injury patients showed that 40% developed sepsis after they developed AKI, compared to 28% in whom sepsis preceded the AKI. So actually AKI is considered to be a higher predictor of developing sepsis. And the mortality rate was similar because ultimately they all got sepsis-associated AKI. The mortality rate was similar between the two groups. Both the groups had a significantly higher mortality rate, risk of requiring dialysis, and a longer hospital length of stay compared to patients with AKI without sepsis. So as I said earlier on, uremia is associated with immune dysfunction, impaired leukocyte trafficking, and cytokine regulation. So it basically causes a state of immune suppression as well, and predisposes you to getting now sepsis because of the virulent microorganism. So if you look at the pathophysiology of sepsis-associated AKI, it remains incompletely understood. All of us have been called to see a patient who is in the critical care unit, and we have been told that, yeah, the patient has become oliguric. And you go through the notes and you realize that, yes, since the patient became oliguric, and this is for the septic patients, the first thing and the knee-jerk reflex that everybody does is, yes, give a bolus of fluids, give 500 mils of normal saline, or give 1 liter of normal saline. It doesn't work, give another 500 mils of normal saline and see whether there's going to be any response. Because everybody assumes that the main pathophysiology of the AKI in sepsis is basically going to be hypoperfusion, which is not true, because rarely do these patients tend to respond to the fluids. So initially it was thought to be a disease of the renal macrocirculation resulting from global renal ischemia. However, an increasing body of evidence suggests that acute kidney injury can occur in the absence of hypoperfusion. Remember that in sepsis, basically your cardiac output tends to increase because you've got vasodilatation of the blood vessels because of the inducible nitric oxide. So there is increased cardiac output and there is increased renal blood flow as well. And yet these patients tend to get acute kidney injury. So it is not purely because of hypoperfusion. And Prowl et al. Actually demonstrated that decreased renal blood flow was not a universal finding in patients with sepsis-induced acute kidney injury. Murugan et al. Demonstrated that acute kidney injury was a common condition even in patients without severe community-acquired pneumonia. So you don't have to have severe sepsis or septic shock for you to develop acute kidney injury. And most of these patients were never admitted to the intensive care unit, nor did they suffer from hemodynamic instability to warrant the use of vasopressors or inotropes. So a consistent finding in sepsis, independent of the severity of AKI, is the presence of, one is microcirculatory dysfunction, there is inflammatory response, and the bioenergetic adaptive response to injury. The way how the organ responds to the insult. So sepsis is associated with an orchestra of cellular mechanisms which are both adaptive and can become maladaptive, which potentiate each other and ultimately give rise to the acute kidney injury. Remember what we talked about, that the focus of infection can be in the lungs, but you can get widespread multi-organ dysfunction, especially because of the cytokine storm. The microcirculation is perhaps the most important compartment where these mechanisms come together and exert the deleterious actions. So we talked about the fact that you get quite a bit of endothelial dysfunction, especially at the microcirculation level, which leads to release of your procoagulant factors, your tissue factors, and this leads to laying down of microthrombi. So these mechanisms include endothelial dysfunction, which I talked about, inflammation, coagulation disturbances, and the adaptive cell responses to injury, which can either be by replacing the cells with fibrous tissue. So this is a cartoon now demonstrating the pathogenesis of sepsis-associated acute kidney injury. Now what happens, especially at the level of the kidney, is that you tend to get an afferent constriction with efferent dilatation. So the afferent constriction, because of the fact that there's a lot of leakage of from the capillaries because they become more porous because of injury, you tend to get a state of hypoperfusion, and the body needs to conserve the blood pressure and the volume of blood. So what it tends to do is that it considers the kidney to be a non-vital organ. So basically it leads to afferent vasoconstriction, and this leads to reduced blood flow. Then we have our cytokines, and we have our the pathogen-associated molecular proteins and the damage-associated molecular proteins, which are produced from the blood vessels. And these are filtered in. And these subsequently bind on to the uh, tubular cells, the epithelium of the tubular cells, and activate the inflammatory response. And subsequently, you tend to get your neutrophils and other cells coming in, being attracted to this because of the inflammatory response. And this subsequently leads to damage to the tubular epithelial cells and leads to acute tubular injury. Now, if you look at what happens basically at the level of the tubular cells, it can lead to either a cell cycle arrest, the one that is highlighted in red, or it can lead to apoptosis of these tubular cells. And this is why you tend to get acute kidney injury, and it normally is an oliguric type of an acute kidney injury. So all of this is basically because of the unregulated host inflammatory response. You tend to get the filtration of your damage-associated molecular proteins from the endothelium, your pathogen-associated molecular proteins from the bacterial cell walls. They all tend to come down, they bind to the toll-like receptors, activate the inflammatory cascade, and subsequently lead to an inflammatory response within the lumen of the nephron. There's also the afferent arteriolar vasoconstriction leading to hypoperfusion of the kidney as well. So how about the diagnosis of acute kidney injury? Dr. Sokala has gone through this, the KDIGO classification of the acute kidney injury, where we have the different stages of the acute kidney injury. And remember that we always tend to use two parameters or two variables. One is the serum creatinine and one is the urine output. Now, the serum creatinine, as I had earlier mentioned, is not one of the best of markers. We are still looking for our holy grail. Like what we have in cardiology, the holy grail is the troponins, which basically rise immediately there is injury to the myocardium. Unfortunately, the rise in serum creatinine is quite delayed because of the fact that there is secretion through the proximal convoluted tubule of the serum creatinine. And the proximal convoluted tubule's capacity to secrete creatinine is increased when there's glomerular damage. So by the time you're getting a rise in your serum creatinine, it is going to be quite delayed as well. Number two is that the serum creatinine basically is not produced at a steady state. So there are various factors that can affect your serum creatinine, like your muscle mass, whether you exercise or not. Your diet can also affect the levels of creatinine sometimes as well, especially when you take supplements. So the urine output tends to be a bit more sensitive when it comes to diagnosis of acute kidney injury when you're dealing with sepsis. So these are the various stages of acute kidney injury. I will not go through them because Dr. Safala has elucidated them quite well. Now, when you look at the laboratory findings in acute kidney injury, you can differentiate pre-renal azotemia versus intrarenal azotemia, looking at your BUN to creatinine ratio, your fractional excretion of sodiums, your fractional excretion of ureas as well, the response to volume, the urinary sediment. Now, one important thing that I've come across is what is called the furosemide stress test. And the furosemide stress test basically is used in patients with septic shock who are oliguric. And it basically works to assess your tubular function and to see whether your tubules are intact or not, the integrity of the tubules is intact or not. And we have all been doing it. It's just that we never knew that it was called the furosemide stress test. And what we do is that for those patients who are volume replete, we tend to give them 1 milligram per kilogram of a furosemide challenge. Or if somebody has been on a diuretic before or has been on furosemide before, we tend to give them 1.5 milligrams per kilogram. If the patient produces more than 200 mils within 2 hours, it means that the tubules are intact. and this patient is going to have a faster recovery. So this kind of helps you to gauge whether the patients are going to recover faster or not. One, and two is that whether you can challenge them with furosemide. So as I mentioned earlier on, in septic AKI, our various biomarkers will not help. So this was a statement produced by Bagha et al. I think he was the same guy who also did the trial that Dr. Sopala was mentioning. He said that in septic AKI, biochemical analysis of urine using the standard measurements of sodium, urea, and creatinine, which are helpful in calculating the various indices of tubular function like your phenas and the fractional excretion of ureas, is not diagnostically accurate, prognostically valuable, or clinically useful. So you can see that we are also at a dilemma right now, because we serum creatinine basically it takes, I mean, it's not one of the best of markers to use, especially in septic AKI. The other important thing to remember is that in septic AKI, the patients have been really rehydrated, especially after the early goal-directed therapy principles came in. So this tends to cause a dilutional effect and gives you a falsely low serum creatinine as well. So we are still looking for the holy grail. And there are the pitfalls in the use of creatinine. I mentioned most of them. It's a late and an insensitive marker of kidney injury. Because of the half-life of creatinine, the increments in serum creatinine concentration lag decrements on GFR by hours. So you can get your acute kidney injury, but the GFR reduction will not be immediate. The time to achieve a new steady-state concentration that fully reflects the GFR loss is delayed by multiples of a prolonged serum creatinine half-life, reflected in changes over days rather than hours. So this becomes important because we tend to use a lot of these equations trying to assess the eGFR, the estimated GFRs, and trying to categorize where our patients fall, and also use it to dose our antibiotics as well. But remember that all of these equations were not used in acute kidney injury patients. The hemodilution, as I mentioned earlier on, in septic patients receiving aggressive fluid resuscitation with a positive fluid balance masks the serum creatinine increments because of a dilutional effect. Now, sepsis directly has been shown to reduce the muscular production of creatinine as well. So you will not be producing creatinine at the same state as you are before as the patient was before the patient became septic. So the creatinine will still be falsely low as well. The renal resistive index is a promising investigational tool. A higher resistive index may be predictive of acute kidney injury in patients with sepsis. It may also be useful in measuring the renal perfusion during vasopressor therapy, because remember that sometimes when you're giving vasopressors, it can lead to a potent vasoconstriction of your afferent arterioles as well. It may be helpful to differentiate between transient and persistent AKI. However, it has also got its own drawbacks as well. It can be influenced by various factors like patient's age, the arterial stiffness, intra-abdominal pressures as well, especially in patients who have got intra-abdominal compartment syndrome, either because of intestinal obstruction or ascites. And very importantly, it's also operator dependent as well. We have the newer biomarkers, like the functional biomarkers like cystatin C, and then we have the damage biomarkers like your NGALs, interleukin 18, KIM1, the TIM2, and the IGF-BP7. Now, these are very sensitive when it comes to acute kidney injuries. There have been trials in sepsis as well. Unfortunately, they're not really available, especially in developing countries and in sub-Saharan Africa. So we are still stuck with our good old creatinine and urine output as our biomarkers of acute kidney injury. So this was a review of 14 studies looking at the urinary biomarkers in septic AKI. So the urinary interleukin 18, PF, and NHE3 detected early in acute kidney injury prior to the development of overt kidney failure. And these markers were higher in septic than in non-septic AKI patients, so they were quite specific and sensitive. So several additional low molecular weight proteins and enzymes may be evident earlier in the urine of patients with AKI. However, their value remains unclear. So we can use these biomarkers if it is available. Unfortunately, they are not available in Kenya so far. So we still have to use our clinical judgment and our creatinines and urine outputs. The most important thing, of course, is to treat the cause of the sepsis and prevent the patients from going into septic AKI. So this was another study that was looking at the urine interleukin 18 as an acute kidney injury biomarker in critical ill patients. And what they found was that in AKI patients, the urinary interleukin 18 began to rise at day 2. And so it is quite early by the time that it begins to rise, and it's very sensitive for sepsis and sepsis-associated AKI. Urine NGAL was another marker that was also looked at as an early marker of acute kidney injury in critically ill children. And again, they found that it was quite sensitive when it was compared to the controls. And they use a rifle criteria here. And as you progress down the stage of the rifle criteria, the rise was much more significant earlier on. So what is the management of septic acute kidney injury? One is, of course, we have to give supportive treatment to prevent organ damage and improve survival in sepsis. Remember that we had talked about early goal-directed therapy, where there was the issue of giving volume until you reach a CVC target of between 8 to 12, and the use of pressors. But we need to be judicious in our fluid therapies as well. Very importantly is the early administration of the appropriate antimicrobial therapy. Restoration of tissue perfusion and optimization of hemodynamic status is quite important. So if you the pathogenesis of sepsis basically is the third spacing that occurs and the vasodilatation that occurs. So it is important to know that we can give up to 30 mils per kilogram as a bolus, which has been recommended by the surviving sepsis guidelines. Now, of course, we have to assess our patients continuously when they come in with septic shock. So judicious use of intravenous fluids, because fluid overload has been associated with worse outcomes in numerous studies. We need to avoid nephrotoxic agents where possible. So avoid giving contrast unnecessarily, especially for contrast scans. Avoid using aminoglycosides, polymyxins, and amphotericin B unless if the benefit outweighs the risks. So this is a cartoon depicting the clinical course of sepsis-associated acute kidney injury and its various outcomes. So this important one is that you need to recognize early the sepsis and AKI so that you can give optimal resuscitation, early antibiotic administration, and the avoidance of nephrotoxic insults, as we've talked about. So once when the patients develop sepsis-associated AKI, it's important that we offer them timely organ support. Again, we still have to avoid nephrotoxic insults and fluid overload. If the patients recover, please monitor for relapse. Don't sign off the case as long as the patient is in the critical care unit. We don't know whether there is a role of blood purification or not. I'll be giving a talk about that tomorrow. I am a proponent of blood purification therapies and pharmacological, of course, the role of pharmacological therapies in terms of treating the sepsis. So once when somebody gets sepsis-associated AKI, they can get an early reversal if treated appropriately, and they can either go into complete recovery, or they can relapse, or the patients can get a partial recovery, or no recovery, or they get acute kidney damage, which subsequently can lead to death or chronic kidney damage. Now, the acute kidney damage can also make a complete recovery as well, but for those who have attended my previous talks, there's one slide that I always like, showing you that a normal creatinine does not mean that the patient has got a normal kidney function. Your renal functional reserve can be very low, yet your creatinine is still within the normal range. Let's say one small insult, like the patient takes an NSAID or gets a small infection like malaria, a simple infection like malaria, then tips them over completely into end-stage kidney disease. Okay, so it's important to remember that. Antibiotic therapy for patients with septic shock and severe sepsis, you need to begin your intravenous antibiotics in the first hour of the recognition of sepsis or septic shock. And you need to use the drugs appropriately. So we need to consider our antibiograms, okay? We need to consider our epidemiological patterns of the microorganisms and the susceptibility patterns in the community and in the hospital. So it's important to have your antibiotic stewardships. So from surviving sepsis 2008 up to now, they all say that we need to begin our IV antibiotics as early as possible and always within the first hour. It's considered to be the golden hour of recognizing severe sepsis and septic shock. So Kumar et al. In 2006 actually showed that each hour of delay in antimicrobial administration over the ensuing 6 hours was associated with an average decrease in survival of up to 7.6%, which is quite high. So if you delay your antibiotics by up to 6 hours, that can give you up to 50% decreased chance of survival. And if you administer your antimicrobial, which is effective for the isolated or suspected pathogen, which is appropriate, remember that word, yeah, within the first hour of documented hypotension, this was associated with a survival of up to 80%. Now, another important thing he found out was that a longer duration to antimicrobial therapy was also associated with an increased incidence of acute kidney injury. And of course, you know that acute kidney injury with sepsis was associated with a significantly higher odds of death. So early and appropriate antimicrobial therapy is a key to improve your chances of survival and also reduce your incidence of acute kidney injury. The wrong antibiotic increased mortality by 50% in septic shock patients. So it's important to know that, yes, you can give a broad spectrum antibiotic, but and it's important to give it within the first hour. And then subsequently, you can de-escalate after 48 hours when you got back your cultures and tailor your antibiotics to the bacteria or the pathogen that you have isolated in the lab. But if you give a wrong antibiotic, like if you give a narrow spectrum antibiotic that does not have anti-pseudomonal cover and the patient is suffering from pseudomonas as a cause of his sepsis or septic shock, then your mortality will have increased by up to 50%. What are the common pitfalls in the use of antibiotics? Number one is I should wait for a source before starting antibiotics. And unfortunately, I preach this and I'm still seeing this currently, that, oh yes, there's no source. The patient is hypotensive, the patient is febrile, but we need to wait for a source before we can give any antibiotic. And a lot of times I've seen people just writing there, consider stopping antibiotics. The other one is that I must know the creatinine before giving the first dose. Yes, remember that the first dose basically is just going to be the loading dose, and it is not dependent on the creatinine. You can always get your levels after, or you can adjust after knowing your creatinine, but the first dose is very important to give. And you can always give the loading dose because that will not harm the kidney. People always underestimate the importance of the loading dose. And in my unit, I always stress that you always need to give a loading dose. All the antibiotics have a loading dose. If you look at Azobactam piperacillin, you need to give a loading dose of 4.5 grams, followed by, after 1 hour, 4.5 grams QID. The other pitfall in the use of antibiotics is that narrower coverage is fine if I have a suspected source. That is not true because a suspected source, we don't really know for sure. And of course, inappropriate selection of antibiotics for the treatment of a pneumonia. The empiric coverage for healthcare-associated pneumonias, which has been scrapped off this in all slide, or hospital-acquired pneumonias or ventilator-associated pneumonias, you have to cover with an anti-pseudomonal drug, and with or without vancomycin or linezolid, depending on your epidemiological patterns of your Staph aureus. And you should also cover the microorganisms with a macrolide or a quinolone if it's suspected that you're dealing with atypical microorganisms. So this is my last slide. So in summary, the prevalence of sepsis is increasing worldwide. We have the newer definitions of sepsis and septic shock. Remember that initially, in the initial surviving sepsis guidelines, we used to have SIRS and then sepsis, severe sepsis, and septic shock. Now we have gotten away with systemic inflammatory response syndrome, or what is called as SIRS, and severe sepsis. It's just sepsis and septic shock. And for sepsis, we tend to use our SOFA score, which is a sequential organ functional assessment score. And septic shock, which is not responsive, hypotension, which is not responsive to adequate fluid resuscitation or a lactate of more than 2. Septic AKI has a worse prognosis than sepsis without AKI and non-septic AKI. The pathogenesis of septic AKI is more complex than what was previously thought. It's not only due to hypoperfusion, there's inflammatory response, there's the response of the tissue itself to the inflammation. Multiple factors contribute to sepsis-associated AKI. Unfortunately, in terms of our diagnostics, creatinine is not one of the best biomarker to help in the diagnosis of early septic AKI or sepsis-associated AKI. We have the newer biomarkers, which may help us in early diagnosis of sepsis-associated AKI. And treatment of the cause of the sepsis is important for us to prevent acute kidney injury in sepsis. So I'll stop there and take any questions.
Thank you, Dr. Bagha, for that excellent talk. There are several questions, but both of the questions are on antibiotic dosing in AKI, where the GFR might not really be the true reflection of the kidney function. So they're asking, how do you dose antibiotic in AKI sepsis?
Yeah, so that's a very important question, and in my unit, basically, as I mentioned earlier on, that most of these EGFRs and the formulas or the equations that have been come up with the CKD epi, your Cockcroft-Colt, and your MDRD equations, which are commonly used, were not for acute kidney injury. Because for acute kidney injury, remember that the creatinine has not reached a steady state. Okay. So yes, initially, as I mentioned earlier, that we do not wait for the serum creatinine before giving our loading dose, and irrespective of the antibiotic that you are using, remember that even vancomycin and amikacin, your Meronem, your tazobactam piperacillin, all of them have loading doses as well. I would tend to wait for 48 hours, trying to assess and see whether we are reaching a steady state in terms of your creatinine before trying to reduce your doses, because there are several factors when it comes to sepsis and septic shock. Remember that the volume of distribution also goes up because of the fact that you're third spacing and your capillaries have become very leaky and permeable, hyperpermeable. So there's a lot of, there's an increased volume of distribution of your drug as well. So you need to actually, some of the experts like Professor Guy Richards say that you have to double the dose of antibiotics in septic shock. So what the conventional dose is, he would always double the dose. And I had the privilege of working with him in South Africa. So you have to just assess each patient individually. There's no answer to this question. I don't know if Dr. Twahir or Dr. Sokala, if he's present, he would want to weigh in here, because I know that we work together with them as well, and we always face with this dilemma.
Yes, Hussein, I agree with you. AKI is it's very difficult to get a steady state. You don't know where your GFR is, so I agree with you. Hitting hard earlier, and especially if you're on things like CRRT, so full dose is the one which is recommended. Thanks.
Dr. Twahir?
I think, first of all, defining GFR in AKI doesn't make sense. I'll give you an example. Somebody develops septic AKI, the urine output drops to 0, but the creatinine is still 100. What's the GFR of this patient? If you work out with a CKD epi, it'll give you a GFR of about 50, 60, 70. But if there's no urine, means that the GFR is 0. So that just shows you can never use GFR in AKI. In dosing antibiotics in AKI, it's recommended that you use the full dosages in the first 48, even maybe 72 hours, because most patients with AKI will recover, and if they don't, then at this stage is when you start adjusting now for your renal dysfunction. Otherwise, you'll be underdosing patients with low dose suboptimal antibiotics.
I fully agree with you, Doc. Actually, right now, I do have a patient in the intensive care unit at MP Shah Hospital, and his creatinine has remained 50-60 for the past 48 hours. Yes, yet his urine output has dipped from 1.5 liters to 800 to 500 mils, and he has a huge positive balance. So there's a dilutional effect that you're also getting because of the sepsis-associated AKI. I mean, the sepsis and septic shock. So I mean, there are no guidelines to this, but I do what you do as well. For the first 48 hours, I would not dose adjust the antibiotic per se. Hit hard, and Dr. Tasneem, back to you.
The question is, why is GFR included in the rifle criteria?
GFR is you see the we don't tend, okay, I personally don't tend to use the rifle criteria a lot because I find it a bit more cumbersome. I tend to use the AKIN and the KDIGO criteria to define the stage of acute kidney injury, which does not tend to use your glomerular filtration rate. So I'm not sure as to why they would be using the GFR. I don't know if Dr. Twahir, you have any comments about the rifle criteria and the use of GFR?
I think, as you've earlier alluded to, in the past, it's mainly for research purposes. There's been no consistent results or literature on AKI because everybody would give you their own definitions. So according to me, a lot of these definitions for the rifle AKIN and KDIGO for AKI are mainly for research purposes rather than for practical purposes. I'll pose the question to the audience. How many times do you have a patient who is in AKI with hyperkalemia and pulmonary edema, and you ask yourself, what stage of AKI are we in? If you look at the AKI studies, the only reason was why they use them is to standardize their patients so that you can compare rather than for practical purposes. So despite these definitions of AKI being there, in practically, none of us will use an AKI criteria to decide whether somebody should be on dialysis or not.
Exactly, and then I don't think that any of the criteria had eGFR as one of the definitions for acute kidney injury per se, because they only use serum creatinine and urine output.
Yes,
So there
Doc,
was
I
no
also think the
eGFR.
same. There's no
There was no
GFR, it's just
eGFR
creatinine
for the
levels.
rifle. It was creatinine, and I mean, we had done a comparison of all the three at one point in time. I remember during my residency. So there was no eGFR per se there in any of them.